Okay, so this is a lot of information to try to present in a short amount of time. So we'll do our best. What this is kind of reworking of a discussion that I did several years ago to try to analyze or give some information for people who interact with seizure patients, but may not necessarily be epileptologists, and some of them aren't necessarily neurologists. But it actually is something that hopefully has some information for other physicians, maybe even patients. I've used it in those settings. So we're going to talk about how epilepsy interacts with other medical issues. And at the end, I put on some new material, basically pulling together some of the treatment options that we have, sort of a laundry list. So you may want me to send this out at some point and email it to you so you can look it over a little closer. So it depends on where you look in terms of what you actually see when you're thinking about something like epilepsy. And that's also true within sort of thinking about where epilepsy seizures come from, because depending on how you look at the seizures, you can come to different strategies for categorizing them, treating them, all sorts of things. There's actually two schools of thought, at least two well-developed schools of thought in terms of how to categorize seizures, with sort of secondary approach sort of propounded by Cleveland Clinic and a lot of people trained there. And then there's most other people will go through a semiologic analysis. Okay, so consequences of seizures. What do seizures actually do? The problems that patients have to deal with include a long list of things. Trauma from ictus. I see patients probably on about a monthly basis where they've had a severe seizure and actually had unprotected trauma. They may have had a fracture, they may have had a dislocation, they have falls, they can go downstairs, they can hit their head after the seizure. These are serious issues. They're not usually life-ending, but they can be. Oral trauma is very common with generalized seizures, and it depends on the seizure pattern for the patient. So if they always have generalized seizures, they're likely to always have oral trauma. Todd's paresis is something we see quite often after seizures, and it's often confused for stroke. And if you have an unwitnessed paresis and it came on and you don't really know what happened, Todd's is in the differential. So this is sort of unwitnessed stroke as well as unwitnessed seizure in the differential. Post-ictal encephalopathy occurs quite frequently, particularly generalized seizures, but also those are partial complex or complex partial seizures. And then there's some consequences of seizures that are just part of what it should be passed on to patients. I think it's part of our patient handouts at this point. Ictal care, what do you do when they actually go through a convulsion? Put them on your side, supportive care, you don't put anything down their throat unless they're turning blue. Contact EMS if it persists or it's the first seizure or anything atypical about it. Medical consequences of seizures, status epilepticus. Now, here this breaks off actually a separate talk, but there are different kinds of status epilepticus. Depends on which part of the brain is continuing to seize. You can have partial or simple status that results in persistent deficits or persistent sort of cognitive functions. You may have trouble with sort of a burning sensation that won't go away. You could have trouble with speech that persists for a while. Generalized status becomes more life-threatening over about 30 minutes, with the mortality figures going up quite a bit. Actually, there's a jump at around an hour, and there's another jump that is actually higher mortality about 1 day. You can't solve the status by one day or 24 hours. Generally, the prognosis is not very good. Outcomes, however, depending upon how badly the cardiopulmonary system is taxed. And obviously, if the patient isn't breathing during status, that's not a good prognostic. Aspiration common, pneumonia is common in status, and rhabdomyolysis is common with generalized status. Okay, sudden death, SUDEP. It's mostly in patients with poorly controlled seizures. There was some data that I saw at the last meeting which says that the more patient gets sort of into the workup, meaning that maybe they are about to be cured with surgery, they're actually the risk of sudden death goes up. I don't know the reasons for that yet. But there seems to be some correlation. If the seizures are well controlled, it's a lot lower. 1 in 2,000 is the usual number. Exacerbations of seizures. These are again reasons. Why is this patient seizing now? What's different that makes it more likely at a given moment in the emergency room or seizing at home? Fever is a big one. Infection, particularly bladder infections, are the combination. Bladder infections don't have to be overtly neurosepsis. You can have just a little bit of a bladder infection, say an elderly patient with growing cramp, enhance the risk of seizures. It also enhances the chance of encephalopathy. Pneumonia definitely changes your risk of seizures right at that time. And any change in medical regimen, which means non-compliance, actual physical change by the doctor from a regimen that's working to one that doesn't work as well, dehydration, again, missed medicines. Okay, treatments and medications for seizures. I'll go over some of the choices in sort of over the last few years at the end of this as well. To make him better, make him take 16 of these a day until we feel better about what we're doing to him. So this is the risk of the actual treatments, is that a lot of the treatments are perhaps worse than some of the seizures. So you have to bear that in mind as we start to go through the potentials. Medication effects. The induction of seizure control. There are some side effects to the medicines, and enzyme induction is triggered by some of the older medicines, listed here, Dilantin, Tegretol, and phenobarbital. And another older medicine, Depakote, which is still, all these are still used, has a suppressive effect on selected liver enzymes. You can also get irritation of the liver rather than just changing the metabolism of the liver. And you can get basically cardiac issues, particularly QTC, abnormalities. Dilantin is not necessarily a good choice. Dilantin also has, I'll mention later on, zero order kinetics. And it's the only medicine I know of with that property, but it's probably not the actual only medicine. It's just the only one I know of, which is more restricted pool. Basically, it doesn't matter how much Dilantin you give to the patient will metabolize a set amount for their metabolism. And you can add a boatload of Dilantin, it still won't metabolize anymore. It doesn't self-induce. So that's why Dilantin dosing has a threshold effect. When you cross over a certain level, you build up Dilantin. If you're below that, you will probably clear it before the end of the day. So levels are notoriously difficult to control, particularly if there's other medicines on board that are enzyme active. Other things that can happen with a lot of the older medicines, changes to white cells, red cells, platelets, so anemia, pancytopenia, and also a big spectrum of things. Some of them also affect electrolytes, particularly carbamazepine, oxcarbazepine. Bone redistribution. This is a problem more with the older medicines, Dilantin and phenobarbital. Lesser extent, bone just didn't get used as much. And there's remodeling of the bone noted with these medicines. We used to recommend, and we still recommend, calcium supplementation and consideration for the medicines for osteopenia as well on occasion in older patients. Fever of unknown origin, you can get with a lot of the older medicines. It's a lot less common with the newer medicines, where we still get consults occasionally from epilepsy or neurology, because the patient has a fever, they're on seizure medicines and the new ones, and they want to know if it's the seizure medicine. Usually it's not with the newer medicines, but it sometimes helps to change it around. And then other side effects from meds. Other side effects, lots of dizziness, trouble with walking, drowsiness, those are probably top on the list. Rash should be up high. It's not on there. Mood control issues, nausea. Let's back up a second to mood control issues. This one is a major issue and has become more of an issue actually with the newer medicines. so specifically Keppra or levetiracetam. The incidence of it is not high, but and there's the strategies to use vitamin B6 to counteract it, which I haven't had much of a chance to try. Typically, it becomes limiting if you hit those issues with side effects. Other things are sort of common for older medicines in general, and seizure medicines in particular: nausea, diarrhea, constipation, slurred speech with high levels, tremor, particularly Depakote, is a big player there. Headache can happen with some of the older medicines and newer medicines. Lamotrigine is a bad player there. Weight changes, both good and bad, with some of the medicines. That's something to look into. And then hair loss, particularly Depakote. Okay, nerves in the brain. This is Homer's brain. Consequences to the brain of seizures: there's a gradual scarring at the site of seizure activity. Some of this is chicken and the egg. You don't know whether the seizures are causing scarring or scarring causing the seizures. In the end, it probably doesn't matter too much. You've got to stop both as best you can. Gradually, you can get some decline in memory function. Patients will often come to me and say, my memory is not what it used to be. And that's mostly short-term memory. It's partially due to seizures itself, partially due to the medicines. It's a combination. Some of it is straight medicines. And hypoxia is the biggest sort of severe risk that you have for sustained seizures, assuming you have status epilepticus or poor oxygen for more than a minute or so. Nervous system. There's no major impact of seizures on the peripheral nerves. Some of the medicines we use to treat seizures actually help the peripheral nerves. Neuron and limbic are good examples. Stroke and epilepsy. So this plays out in that a lot of patients with stroke have a higher risk of seizures. We're talking about 15 to 20%. 15 is probably closer, versus 2% of the general population. It's leading cause of seizures in anybody in sort of a vascular risk factor age, so over 60. It passes tumors around that time. Tumors are more active between about age 30 and 50. Seizures can occasionally occur simultaneously with stroke, and doesn't necessarily have to be an hemorrhagic stroke, but it often is. When it does happen together, they can be more difficult to control. And the other one where we sort of get seizure and major injury at the same time is severe hypoxic injury. And that seizure may not be clinical, it may be subclinical. Seizures of dementia, quite common. So again, numbers start to go up. It looks almost like vascular. Yes. And that may be a connection there. Poor perfusion is perhaps one of the contributors to Alzheimer's. Seizures are generally controllable in this setting and generally use a lot lower doses, but it still works. Sometimes trying to use older medicines is really a difficult thing with dementia because side effects. So it's been a lot better, say, the last 15 years or so since we've had newer generation medicines.
Would you recommend starting seizure prophylaxis for hemorrhagic stroke or just only when they have possible?
Yeah. Brain tumors. Classic presentation is with new focal seizures. It's usually not the cause of seizures for most patients, because most patients don't actually have brain tumors. There are many other things that can cause seizures, but you do have to screen for it occasionally. The particularly high-risk group actually has the lowest incidence of seizures overall is those middle ages, between say 30 and 50. They have the highest risk of having simultaneous tumor as a cause. Seizures can be resistant to treatment, mostly due to the local swelling. And swelling, again, interferes with sort of the brake. And so how I describe it to patients. Interferes with the brakes that keep the brain from going out of control. End up getting down the hill with seizure. If the swelling persists, symptoms of seizures may respond to steroids. So that's actually fairly common. Used if you've got mass lesion. So we simultaneously give seizure medicine, steroids, and then deal with how to treat the tumor. Resection and radiation therapy are two big modes. MS. MS is a little of a bit of an outlier. The actual data for MS and seizures is about the same as general population. It makes sense considering MS is subcortical and seizures are mostly cortical. But when you meet that MS patient who has seizures, you think that there has got to be a connection. They do have to be treated, both of them, but I don't know that there's a lot of overlap in the therapies. I do have some overlap patients. Due to pre-existing disability in the MS, the effects of seizures may be enhanced. It depends on sort of the status of the MS. Other body systems that get affected with seizures besides nervous system. Diabetes and epilepsy, hypoglycemia can be a trigger for seizures. Hyperglycemia may make focal seizures a bit more likely. And then achieving tight glucose control is obviously helpful in many ways. Epilepsy and cardiac disease. Syncope is a big differential that we face as neurologists. There is a thing I didn't mention, at least on this panel, syncopal convulsion. So syncope, if you have a syncopal event and then don't get enough perfusion for long enough, you can actually go into a full seizure due to not having blood flow to the head. And that would be syncopal convulsion. That would be an interaction too. Generally, low pressure is the issue. Line 5 helps. This is how you avoid convulsion sometimes. If present, the cause of syncope is treated now, it's easier than treating seizures in general. And if there is a treatable cause, you don't necessarily have to treat the seizures. The only time I do is when there's a reason to, when the patient has an abnormality, say on the EEG or an abnormality on the cardiac arrest during seizure is not very common, but it can happen. And then seizures following cardiac arrest, very common. Very difficult to treat. Okay, medication for cardiac disease itself may interfere with seizure medicines. That's mostly the older medicines. Coumadin dosing can be really tough with Dilantin. You just probably don't have to deal with this much anymore. But basically, change the Dilantin a little bit, the Coumadin shoots up, down, it goes sideways, and vice versa. So it's often a struggle to try to do both. You'll only really see this these days when you see a patient that's on Dilantin and for some reason has to start Coumadin. We don't typically add Dilantin onto a clinical patient to avoid it. Alternating epileptic medicines without liver effects are alternative epileptic medications without liver effects are easier to manage. So these are the newer generation medicines. They are easier to manage. And cholesterol meds are affected again by the older medicines. Dilantin, Tegretol. Dosage adjustment will be needed. One other big category of medicines that gets affected is hormones. So birth control pills is way up there. And that's almost a separate topic, but that's something to be aware of as you start a seizure medicine. Usually decreases the level of your hormone and you may need a higher dose. Pulmonary issues. Breathing can also be altered with generalized convulsions. Again, this is the aspiration problem. And respiration during sleep can contribute to respiratory changes during sleep may actually contribute to seizures. GI. Medications often have side effects on stomach and digestive, so it's more of a medication issue. And absorption may be changed in surgical patients. So this would be typically gastrectomies, to things like that. If you had a colectomy, that would change things. And medications can alter liver function. They generally don't shut down the liver in general, but they can from the ones. Okay, dramatically affect metabolism, seizure medicines through the liver. And typically, if you affect the metabolism, we're talking about increasing or decreasing the metabolism, then you extend the half-life. Ammonia buildup can contribute to increased asterixis, and that is a potential downside of some of the older medicines. Seizure medicines can affect liver function, and most common issue with medicine is actually altering the lab parameters, i.e. transaminitis. So your AST, ALT, and GGTP will go up. This is generally reversible intentionals. Kidneys. Kidneys in general are not particularly adversely affected by medicines, with the possible exception of Topamax and Zonogran, which can both contribute to kidney stones. The remainder of the medicines, the interaction here is a little simpler than put up here. It's just that they're excreted by the kidneys. So we're talking about gabapentin and the ones that are listed. And they're not directly toxic to the kidney itself. That said, they will often get stopped if the patient is going through kidney failure, or doses will be adjusted because they're cleared by the kidney. Kidney stones, again, Topamax and Zonogran. Dermatologic issues, rash. That wasn't listed in the main panel of problems. It is not very common these days, but it's a 1 in 10,000 chance in Stevens-Johnson, 1 in 100 chance of a rash with the old medicines. Stevens-Johnson is not something you want to hit if you can avoid it. Oral issues with some selected medications, gingival hyperplasia with dialysis.
Do you still test for the genetic, the HO?
Which?
Like, if you want to solve a Lamictal, do you want to test
Was it
the Asian female? Asian,
Oh.
Asian female,
There's,
yeah.
there's they're suggesting that these days, yes.
You should, right? Otherwise you get sued.
I guess it makes sense. I should read it more.
You might not have that many Asian patients.
Well, not that I'm starting up on that, and actually, yeah, it's the other way around. I don't have that many patients.
It's out here. Asian patient?
Yeah, Asian too.
That's what I'm saying.
Okay.
But Eastern Asian are more common.
Chinese.
More
Chinese.
Chinese.
There's,
No.
It's on the right.
it's an HLA association. I think they found the enzyme. They recently found actually the enzyme. So it's the protein mutation.
I know the mutation.
Okay, endocrine issues. Diabetes sometimes affects seizures. We talked about hypo and hyperglycemia. Diabetes induced by medicines on occasion. This is rare, but I've seen one case or two in years. Topamax can sometimes induce diabetes. Pancreas is rarely irritated by medicines. Again, Topamax is one. Depakote, phenobarbital, and Zonogran sometimes do it. No major interactions with the thyroid from the medicines. Muscular issue, muscle breakdown, ictus and rhabdo. Position after the event is important. So if the patient is compressing something and not moving, then they may have much more likely to have some breakdown. If you don't have a full history, it looks like the patient had a seizure. It's pretty easy to just draw a CP cap and sure not needing dialysis on down the road. It's not a part of the routine ER screening automatically, so sometimes I've actually had to request it. General breakdown is generally breakdown is mild, but it can be severe. And sort of your history or whatever history you have is about nothing. Special cases, pregnancy and seizures. So frequency of seizures during pregnancy is variable and it sort of follows the rule of thirds to the most part. Maybe a few more women go through a little reduction than anything else, but it's about a third and a third and a third, worse, better, or about the same. Be aware again that enzyme inducers, tegotal and topiramate, one more, one of the newer ones that actually impact contraceptive effectiveness. So that could have a role because then they may not be wanting to have a child and the contraceptive fails. Depression. Depression is present in about 29% of seizure patients, so that's about 10% over the general population. Many medications for seizures can, in theory, precipitate seizures. In my experience, that tends to be patient dependent. So it's rare to start SSRI on a seizure patient and have a dramatic impact on the seizures if they're under control. But you can occasionally do it. If you find that, though, it's very selective for the patient and the medicine. So if you have a problem with one of them, you try an alternative, and generally it will go through and there will be no further impact. The way some of this was teased apart was that basically there's a lot of overlap, as 29%, and patients would be treated for seizures, and then of course they'd start the anti-epileptics, and suddenly seizure would go upwards. So they were sort of figured out by that process. Okay, psychosis and epilepsy. Hallucinations can be epileptic, particularly visual, and less so auditory, although that can happen. Maybe a sound more than the voice, it's more typical. But seizures in general are not equivalent to psychosis. So there's an organic cause for the hallucination, meaning that it's not strict schizophrenia. After seizure, confusion can resemble anxiety or psychosis. Patients can be combative, as you might know, and they can certainly be very, very confused. After the events, you can sometimes treat prophylactically. I guess with antipsychotics, I would do that short term as possible because of the effects of the antipsychotics. Dialysis seizures. Some patients with seizures have seizures during or after dialysis due to electrolyte changes, particularly in urine state. And dehydration probably has some role there. Earlier dialysis tends to be protective if they're on a regular schedule, and medication can be protective. These are kind of common sense things. Medications to avoid. Okay, so a lot of medicines here. Some of these are relative do nots, and some are a little bit stronger. In fact, most of these are relative. Amphetamines and stimulants, like for ADHD, several patients that are on both. And once you sort of see the effect of a stimulant, you can safely continue to use it. But maybe that first use of stimulant in the seizure patient is one you want to be cautious with. Antihistamines. So pretty much all the over-the-counter decongestants have some antihistamine in it, with the exception of pseudoephedrine. And they all slightly increase seizure risk. It's not much, but it's some. And some patients are sensitive. Some of the antidepressants, we talked about that. Rapid benzodiazepine withdrawal, you don't want to do it rapidly. You have to do it slowly if it's a seizure patient in particular. And rarely antibiotics sometimes can contribute to seizures. This is mostly older versions of penicillin that was given like penicillin G. And maybe penicillin B. Meds to avoid. Now, this is a listing of the meds, and this is going to go for more pages than you want. So you may want to look back at this. I'll try to make this available. This is a historical listing of things that are still used somewhere, somehow, for seizures. Potassium bromide was introduced before the Civil War, I guess, and it's no longer used in the United States. Have you ever sort of heard of people using bromides in like old novels and things? That's what they're using. It's toxic. It's not usually deadly, but it's toxic. Neurotoxic among other things. So they end up losing quite a bit of intelligence with continued use. The doses they had to use, as far as I know, I never did, were enough to basically make people very drowsy, sedated, and I don't think it was a good thing for the brain. It was killing off everybody. Phenobarbital was introduced in 1912 clinically. It was actually first synthesized, I think, about 10 years before that. And it works by increased GABA activity. It also seems to block glutamate receptors a little bit. It is not particularly effective for strict absence seizures. So we're talking 3.5 or 3 hertz spike in weight. It is available IV. It is sometimes challenging to get the pharmacy to give it a full loading dose and status. It is very effective. Using phenobarb IV generally for status, you're going to have to anticipate intubation. The patient's not going to be able to protect their airway. Still get some use around the world. because it's cheap, it's reliable. It does have some problems, frozen joints, all sorts of bone issues, but it's available and it's manageable. Phenytoin has been around almost as long, 1936. It works on sodium channels, increases slow activation, and also probably slows down conduction through sodium channels. In zero order kinetics make it difficult to manage. Lots of blood draws. It's not bad, not quite as bad as Coumadin, but it's close. It does have side effects. It used to be the primary agent here in America until probably about 1995 or so, somewhere in there. Available as fosphenytoin, and this is kind of a teaching point because I don't know that we still have phenytoin IV available in this hospital, but we do. We do. So
We got yelled by that.
yeah. So fosphenytoin has gone through several cycles of use and shortage. It's a generic, it's very useful for controlling seizures, and it's not nearly as toxic to the body as IV phenytoin. But it's chronically in short supply. So when we can, we use it. If you absolutely cannot, and the patient is seizing, you take your choice of taking and possibly getting a blue limb or trying seeing if the seizure will stop. So the actual incidence of that is not high, but it's pretty toxic stuff. It's straight phenytoin, IV. Phenytoin orally still used somewhat. And it, despite all the stuff I said about its levels and its management, we do have easy screens for it. So in the emergency room, sometimes that helps because they're coming with a low level, and then you can load them up and quickly get home. Acetazolamide introduced in 1952. It's not used extensively for seizures anymore so much as pseudotumor cerebri. It's a carbonic anhydrase inhibitor. It is not available as far as I know. IV, just oral.
I think we do have.
You do have IV? I'll change that.
Oh, I didn't know. Maybe. Maybe.
I didn't see that.
We just gave some more IV diamonds. Dr. Davis does it to his patients are retaining CO2. She uses it to sort of like alkalize them in the
Okay.
She gives it like 500 IV Q8.
Good to know. Okay. Primidone is a barbiturate. It breaks down into phenobarbital. Back up
We
here.
do.
It's only available orally, and it's not really used in the acute setting, but it is sometimes rarely used in the clinic. I know. It's also used for essential tremor, and probably it's more used for that these days. Ethosuximide is for absence seizures, and I have used it in adults occasionally. People will tolerate it up to pretty decent levels. It doesn't have that much in the way of side effects. It works well for absence type seizures. It's worth remembering. And divalproic acid got introduced in 1962. It was actually, it's a lipid. I'm not sure this thing is showing. So probably this got cut off. It's a lipid, and it works through the sodium channels. It was found sort of by serendipity. They were using a solvent in all of their medicines, and everything was working for seizure control.
Yeah.
And we found out, maybe it's the solvent. It has significant issues in terms of side effects. Rash is high among them. It also has significant issues with birth defects, and it's the highest incidence of birth defects by seizure medicines, hands down. It's about 10%, versus the natural background, which is about 1.5%. Mostly it's neural tube defects. It also, there's some data indicating that it may have some second and third trimester issues that impact later development. So you can get some stunted cognition later on. Diazepam, introduced in 1963. It's the first benzo. It's an alpha-2 delta calcium channel blocker, and it also enhances GABA presence in the body for availability for use. Available PO, IV, also PR. Rectal Valium is a staple that's been around for quite a while. They actually introduced the rectal version probably in the 90s. I don't think it was around 63. Carbamazepine, 1965. This is the first medicine that starts getting quite a bit more tolerable with no clear long-term side effects. It has minimal effects on the bone. We used to treat everybody with calcium and vitamin D anyway, and we still do, but the data for it is less robust than all the other ones I just listed. Complex partial seizures is the main target for that medicine, so that's the majority of adults. It's not for myoclonic or generalized seizures, and may make them worse. It's only available orally. That's another drawback. But this was briefly also the #1 and #2 medicine for quite some time, from like the 70s to the 90s. Clonazepam, 1975, benzodiazepine, available IV, wears off very quickly. This is probably why we don't load it up. Wears off. Go back to having seizures. Now, it clears out of the body slower, so you're ending up with toxicity, but seizure persistent. That's not good. Lorazepam is the most actively used benzo right now, available IV, limit to about 10 milligrams to avoid intubation again. That's just sort of a bedside benchmark. But if you go over 10, typically, because of other medicines that may be loaded, you're running a chance of needing intubation on an average weight patient. Okay, Probamate. These are we're getting into some of the newer ones that some of you may not be as familiar with. This is works through GABA mechanisms as well as NMDA. There's no IV formulation. This is mostly for Lennox-Gastaut and a few other rare syndromes. That's where it tends to get used. It does cause liver failure, rarely, and there are some other metabolic issues with it. So, so it's not used a whole lot. I have it mostly for patients that are basically chronic refractory seizure patients. Gabapentin was introduced in 1993 and increased GABA efficacy and calcium channel activity as well. There's no IV formulation. It's also, in practice, perhaps a lesser powerful medicine than some of the older medicines, as well as some of the newer ones. A year later, in 1994, the Lamotrigine came out. This one was kind of a groundbreaker because a lot of patients that had not been controlled became controlled with this medicine. That said, it doesn't do anything that much differently. It works through sodium channels, does increase GABA activity, but it is broad spectrum. It's good for both generalized seizures as well as partial seizures. Rash is its limitation. If you go slowly as you increase it, generally people do well. You can add it even on top of Depakote, though when they first introduced this thing and Depakote, the rash incidence went sky high. You have to go very, very slowly with Depakote's also on board because of the enzyme inhibition.
So we avoid them together.
You can do it. You just have to do it really, really slow. And
It's just like the thing that comes in for someone that put it on your system, the 3 kits.
Yeah.
One of them is
one's enzyme inducers, one's on Depakote, and one's just no enzyme after. That's how they used to do it. Topiramate came out a little bit after that. It's actually a modified fructose compound. It does have a sulfa group. I think the zonisamide also has a little bit of a sulfa component, although it's more buried. So if you have a sulfa allergy, this patient's not going to necessarily do really well with topiramate. Avoid that. The other thing, as we mentioned, as I alluded to when reviewing the neurologic or the kidneys, is that the kidney stone incidence does go up. It has multiple modes of action, and this also made it effective. It also has a bit in the way of side effects that add therapeutic doses for seizures, and that's why it's probably not used a whole lot for adults for seizures. It's used a lot for adults. Sodium channel effects, GABA A receptor agonism, AMPA antagonism, and carbonic anhydrase activity. There's no IV formulation to that. Gabine is another one that we are not going to see a whole lot. It was used a bit for refractory patients. It blocks GABA transporter, GAP1 gene. So it's kind of like an SSRI or an antidepressant, and it's working in the GABA transport. There's no IV formulation. You won't see this a whole lot. In fact, it may actually be out of patent right now, so probably won't see much at all. Levetiracetam was the sort of the blockbuster medicine for seizures in 1999. It blocks the recycling of the synaptic vesicles so that they can't pick up more transmitter and continue the cascade of excitation. Its general purpose does have some psychiatric side effects, about 5 to 10% of patients. It's available in multiple formulations, and typically it's given Q12 hours orally and IV, although the actual half-life is about 8 hours. So it kind of goes in, hits the synapse, blocks the protein, and it's effective for 12 hours on that format. Getting closer to the present time, zonisamide came out around the same time. It's a T-type calcium channel blocker and sodium channel blocker as well. It does get some general use, also used in Parkinson's. I've got to look this up. I'm not exactly sure what it's used for. I believe it does have a sulfur component, although I don't necessarily stop patients from taking it. Wait and see how things go. There's no IV formulation. This is actually my go-to when I don't have the possibility of say that they get all anxious with Keppra. This would be a valid alternative. Oxcarbazepine, introduced in 2000. It's kind of like carbamazepine or Tegretol. Sodium channel is the main mechanism, but it has a different breakdown pathway through the liver because of one little epoxide change, and it's generally better tolerated. It does, however, still have the hyponatremia that we see with carbamazepine, just not as much. So that can sometimes be limiting. And this is a first choice, perhaps, for trigeminal neuralgia, which is what carbamazepine was first used for as well. Pregabalin, 2004, like gabapentin, and there's no IV formulation. This is Lyrica. All right, and then we get into the ones that are still sort of proprietary. Pregabalin, it's about to come on. Rufinamide or Banzel is a sodium. It's kind of like some of the older medicines. A sodium channel blocker. It is used for Lennox-Gastaut preferentially. There's no IV formulation, so this would be a patient that has chronic refractory seizures, probable Lennox-Gastaut, so multiple seizure types, and they'll be on this chronically. It helps some control the seizures.
Carbitrol, is that carbamazepine or oxcarbazepine?
Carbitrol is extended release carbamazepine.
It's
Really hard to get these days because they'll almost say use extended release instead of a main brand Carbitrol. But no, okay, oxcarbazepine. Yeah, and there's another version of oxcarbazepine similar. I think there's one sequential modification that I'll get to in a moment. Banzel, again, Lennox-Gastaut. Vimpat gets a lot more use here in the hospital. Furosemide, it's available IV, which is a big selling point, as you notice. And it's effective. We've started to use it for status sometimes. It generally is pretty well tolerated. So it's a good choice in that setting. For some patients, it helps. Vigabatrin or Sabril is used mostly for kids with refractory seizures. There were some issues with potential peripheral field loss, which seemed to be more than the background that was noted when this medication came out. So that's restricted its use. There are irreversible visual field defects. You have to have sort of bad enough seizures to make the risk of that worthwhile. That said, some people here in Philadelphia have been doing some research, and the visual field cuts are probably pretty minimal compared to what the original reports indicate.
I
Most
think
people.
it produces metabolite that affects the ganglion itself. Yeah, like you have to do visual cue before you start it?
Yes, you do, and then you have to do it sequentially afterwards. So, yeah. Clobazam or Onfi gets a fair bit of use. Again, perhaps more the Lennox-Gastaut group. It's good for myoclonic seizures. That's the main seizure type that you see with Lennox-Gastaut and with generalized seizures. And it's a benzo. It's a little bit less sedating, and maybe a lot less sedating than some of the other ones that we listed, and it has a longer half-life. So it generally works fairly well long-term rather than being limited like standard benzos. Tiga, exogabine, potassium channel opener. So this is one of the, I haven't seen a lot of variability in terms of mechanism. This is one of the first that came out with a different mechanism. It's a channel, it basically is repolarizing the cells. So it's useful for patients that are refractory to other medicines. Has some limits. I haven't, when we get into sort of name brand medicines, it's a lot harder for me working here to get because we have to go through a long approval process. So I don't have a lot of experience with Tiga. Not available as 9B as far as I know. Bicompa, non-competitive AMPA antagonist. That's similar to ketamine. This is the other one that affects OCPs. Again, my experience is limited. There's no IV formulation. These two were promising both because of their use of a different mechanism. This is what we've been looking for like 20 years now, since Keppra started to be developed. Aptium is like oxcarbazepine. It's not identical, but it's chemically very similar to oxcarbazepine and carbamazepine. And no IV formulations. Briviact, brivaracetam. Yes, there's an IV formulation. It targets SV2A just like Keppra does. It's a little bit more selective. It doesn't. Keppra itself doesn't really hit too many other targets, but there's some speculation that it might. This one seems to be clean for the SV2A protein. So it's very non-interacting, as was Keppra in the original. And then we got the one that everybody wants to know about in the clinic, cannabidiol. The data for it being useful for seizures is pointing towards Dravet syndrome. Now, Dravet syndrome is actually a big deal if you're a pediatric epileptologist. That is a huge portion of the intractable, difficult to control seizures that you have. So this is going to get some use, particularly in pediatrics. I think it's also going to get some use for adults, but I don't think the success is going to be as good. Right now, there's a bunch of coverage issues. I'm trying to sort out what I can actually do here at Einstein. And I get to use it sometime soon. ICU for status, there's some additional medicines that get used besides all the ones we listed that are IV formulations. Pentobarbital, midazolam, Reversip, propofol, diplomat. They all have their sort of niche. Beyond meds. So these are the things we can do after the medicines, in addition to the medicines, and instead of the medicines. Epilepsy surgery. We are working on getting that done for our patients here. Some things I'm trying to get through. But that is one method of controlling seizures that come from one focus in the brain. The success rate for temporal lobe is around 80%. For non-temporal, it's more like 50 to 60%. So that's a definite treatment option for patients refractory to medicines. Ketogenic diet. In practice, it's a lot easier for kids to deal with this. It's a very restrictive diet, hard for adults to maintain, but it does work. It does reduce seizure frequency, rare to get complete seizure control. I guess you can with some patients. BNS is very, very rare to get full control. It's a vagal nerve stimulator. It's a little stimulator like a pacemaker that goes up to the left vagus, stimulates it, and resets the limbic system through the vagal pathway. Reduces frequency of seizures, but does not generally eliminate them in my experience. I don't know if I ever fully eliminate. It's adjustable. It does need to be sort of reset after an MRI, at least the older versions of it. I think the new ones have to look better. It has one drawback. If you put it in, part of it is going to be there for a long time. The part that wraps around the vagus nerve is not extractable because the nerve invests into the electrodes, and you can't take it out without hurting the nerve. So that part will remain regardless. And reactive neurostimulation, this is coming online now at multiple institutions. I think both Jefferson and Penn are working on this one right now. But basically, it's if you have a known location for seizure onset, you can stimulate that and it will reset the seizures so that it stops. You just give a little electric stimulation. I think I ran out of time. Thank you for your patience.
I was listening to an article, a conversation on NPR when one thing they were talking about all the things that you implant and go default. Like, I mean, it's something that only the manufacturer made it like not only to vagal nerve stimulator, they want to talk about vagal nerve. Another guy who had a foot implant, and it kind of leaked out everywhere, and he was the owner of that maker.
Oh, really?
So it leaked out like it was, and there was another one vagal nerve that it was like kind of trigger off unnecessarily. Like there was
Oh,
something
really?
I mean, it's something that you cannot predict. Like can happen very rare. Like the moral of the story was like you should really think about placing something.
Yeah.
What happened? I did
Because
something
then you
wrong.
can take it out.
Yes, what happened? I'm so nervous.
Just a quick update on Bradley.
Quick update.
Just a quick, you're looking at the EEGs today.